gone into the minute details. And if people follow the protocol that you are given, I'm sure not only the patients will be protected and patients will be happy, and the staff will be properly protected. The question answer session we'll have at the end of all the talks, since you are all
Sure.
also in the panel. Just one thing I would like to just add on is that one should have a protocol for the patient suddenly coming to the hospital, or even your usual patient who may come with fever, or some mild symptoms. So the
Right.
staff should be instructed exactly what to do, because sometimes if the staff refuses your usual patient for a mild fever or a mild cough, there can be an issue. People can get emotional. So I would suggest that there should be something like a fever corner, and a protocol should be there, a kind of a drill, that if such patient comes, who should attend the patient and who should actually deal with this patient and direction. So minimum staff, maybe only one doctor in proper protective gear, PPE that you have shown, and taking care of that and explaining why they cannot be treated in that hospital and maybe have to be sent for fever centers that government has opened up. I think only that addition. Otherwise, excellent presentation.
Thank
I
you.
salute you, and so it's a online applause for you for doing wonderful thing. And I can see,
Thank you. Thank you. And we welcome Dr. Suchitra Pandit. Suchitra, so
Pandit,
nice to see you here.
yes, wonderful to see Dr. Suchitra. Yes. Suchitra, we can't hear you. We can't hear you. You'll have to unmute yourself. No, still we can't.
No. Ma'am, in the meantime, Suchitra ma'am has joined in. I'll just share your number with Gaurav. Okay. Ma'am, or you, ma'am, you do one thing for me. You share your presentation immediately with Parag, or he can share your screen.
No, listen to me. मुझे बता ना क्या करना है टेक्निकली. उसका बंद करना चाहिए शायद. उसका बंद करना चाहिए.
Okay. Suchitra, we can't still hear you.
Hello. Suchitra? Hi. Can't hear you. We can't hear you. Can't hear you. Okay, thank you.
Okay.
Okay, fine.
I think, Dr. Girija, probably we need to go ahead.
Are you
ready with your presentation?
Yes, I'm ready with my presentation. I'm waiting for the technical support to share my screen. I think they have to put up Parag's presentation, and then only I will be able to share my screen.
Okay.
Parag, can you just stop sharing?
In the meantime, let me introduce you to the audience. That will give them time also. So we have now none other than Dr. Girija WAGH, and eminent speaker of FOXY with us. She is a professor of Gynae in the Bharati Vidyapit University Medical College, and she is a consultant at Cloud9 and Apollo Hospitals of Pune. Right. She has a illustrious academic career, having stood first in her MD in BZ Medical College. And
it cannot be mailing. Too heavy for mailing. You don't trouble me so much. You tell me how to share my screen.
Girija, people can hear you, so a little away from the mic, please. Yeah. She has been awarded Anandibai Joshi Award for excellent medical service, and her specialization is maternal fetal medicine, and especially she has developed a fellowship and an intensive care unit, so critical care fellowship for ICOG in her hospital. She's also the vice president of GESTOSIS organization, the chapter of India, and a steering committee member of World GESTOSIS organization. So she's an expert in preeclampsia, eclampsia, and hypertensive diseases in pregnancy, having helped in creating the guidelines with Dr. Suchitra, Dr. Gorak Mandrukar, myself, and the whole team of ICOG and Foxy. We expect her pretty soon to be elected also as the vice president of our federation. And Professor Girija, if you're ready, you can go ahead with your talk. Can we share Dr. Girija's slides? Dr. Suchitra, it's good to see you there. Unfortunately, we can't hear you, but we can definitely see you, and it's good to have you there.
There is some problem with the share screen thing here, which I'm trying to sort out. Just a moment.
Okay. Okay.
It's suddenly saying that it has lost the permission to share the screen, and I don't know what to do about it. I'm just waiting for some technical assistance. Aditya. So, I don't know. He's saying, I can't share this screen. Can you help me here?
So, what are you presenting?
There's a PPT already on my screen.
Where is it?
It's on the screen, main screen.
बघ ना इथं तर application लिहिलं नाही उघडेल PPT.
See, nowadays youngsters are better at all this, so I think.
No, I totally agree. We have to rely on them 100%. Just the other day, I was having a webinar with Chandrapur, and when the thunderstorm was going on, and then I faced a lot of challenges, but my son was there to help me.
That's good.
I'm not sure what.
Parag, can you elaborate on some of the issues that you discussed in your talk then till then? People might be having.
So I think let's let Ajit start, because we'll have a lot of questions in the panel discussion also. So let's not barge into it. So if Ajit can start, we can have his presentation first, followed by Girija.
I'm not sure.
Can I ask a question to Dr. Parag?
Yes, go ahead. Go ahead.
Yeah, because you have all highlighted that it is on private clinic. But what about public hospitals? The public hospitals patient just drop in. You don't have anything beforehand.
Yes.
So for that, you should have given some messages just for the public hospitals.
Okay. Basically, Saswati, since I work in a private setup, I do not have any idea as how the public hospital OPD functions. My last exposure to public hospital OPD was in 1992, and after that, I have not been attached to a medical college. Right. So maybe you, as a professor, and Ajit also is a professor at Kannur, so maybe two of you can throw light on it, because it is really difficult in a busy OPD. Yeah.
Dr. Ajit, can you give us some ideas how you are doing there in Kerala?
See, about the general antenatal care, what we do is we tell the patients to come for the regular checkup, because we consider it as an essential service. But some modification, that is after first visit, they can come for the NT scan, then for the anomaly scan. So you can club the investigation along with that. Then whenever they come to the hospital itself, they are asked some questions. Are you having fever? Any respiratory infection? Any respiratory symptoms?
Your questioning is different, but as somebody, your preparation of your antenatal clinic.
That I'm coming. Yeah. So if everything is negative, then they will be attending the normal antenatal clinic. And
so
what we do
in screening area.
In the normal antenatal area. But if there is any travel history, any contact history or something, they will be going to triage.
Before entering to the antenatal clinic, there should be an area which is a screening area where the history is being taken.
Yeah, there is even before entering the. Yeah, we have a screening area where we ask these questions. We check the temperature and everything. Then they will be entering. Then they will wash their hands. There is a facility for washing the hand. Then they will be using a mask, either a cloth mask or at least a cloth mask they had to wear. Then in the OP, what we do is the doctors wear a 3-layer surgical mask.
Yes.
3-layer surgical mask. That is all we. Then they. But the gloves, the problem with the gloves is that each time you have to change the gloves. If you have the facility to do all these things, okay. Otherwise, what we do is after seeing each patient, we sanitize our hands.
I think that's more practical.
One thing we do is mask, sanitize the hands, and then the social distancing.
In our medical college, what we have done, first the patient comes to the screening area, we just reduce the number of attendants. Attendants don't enter inside the antenatal clinic. They just wait outside in the waiting area. And once we have some problem, something to discuss with the party, then only we call them. And then the mask is a must. And after screening, they get a chit that a checkup has been done to this particular patient. Then after that, she gets the entry to the proper antenatal clinic where she gets the tickets and all these things. So that's what we have done in our medical college as of now.
Exactly, that is
quite right. I think masks are the very, very important thing, and washing hands is also critically important. You might have heard Tul Gawande yesterday, when he was on one of the TV channels, that they have in their Madison City, Madison Hospital, University Hospital, 75,000 employees, healthcare workers, and they have been able to avoid, the spread just by, these 3 or 4 things, and mainly the mask, mainly the washing of hands, and the social distancing. So these 3 are important. I think the shields, which are very simple, and these shields, if we can use, then I think that's a further addition, and which is very simple. I think Professor Girija is now. Professor Girija is ready with her talk.
Yeah.
Now we can see her slides. So please go ahead, Professor Girija.
Okay.
Again. Now, do you, Dr. Ajit, again, because I think she's again problem. Do the doctors who are there in the antenatal OPD, in public hospital I'm talking, you are using a 3-layer surgical mask and gloves. That's it, isn't it? Or you also wear some PPE kit for each and every patient, because in public hospital you don't know sometimes. Indeed, the screening is there, but even then, do you use that PPE kit for just doing that simple antenatal checkup?
No, we don't use. Only in the triage area, we use. If there is anything to suggest any contact travel or clinical symptoms, then we use the PPE, the full PPE we use.
Okay. So just a 3-layer surgical mask and a pair of gloves is sufficient to take it.
And just sit in the OP for 4 to 6 hours with PPE is not that easy.
No,
it's
Agree. But what we need to do is, now there are modified PPEs which are washable, reusable, and very light. and they are something that our residents should be using, because there will be many asymptomatic patients. As we know, now we are finding that almost 80% of the patients are asymptomatic, and asymptomatic stage is also an infectious stage, and that's why use of there are very simple and very cost effective face shields are there, and very cost effective. They may not be full PPEs, but they're gowns which can be washed, which can be sprayed by our hypochlorite solution. They can be sterilized if required, and I think at least those are the ones should be used by OPD personnel now, because how do you know that person is not even if you've done a test, in 34% of the cases tests are coming negative. So how do you know the patient is not already having symptoms? So I think we have to have a little more protection than just depending on the mask, and especially in places like Mumbai and Pune, where now the
numbers are increasing.
Really going high up.
Suppose the patient is already, you have a suspicion, like she has ILI or maybe SARI even. So you cannot refuse antenatal checkup for that. So for them, how do you, Dr. Ajit, please? How do you proceed?
See, they will be coming to the triage area. So we will be seeing with our full PV, and definitely we give all the essential antenatal care we give. If she wants an investigation, we do it. But of course, if you can defer it, say ultrasound, if you can defer to 1 to 2 weeks, definitely we defer it. Okay. Otherwise, we do give the essential service. We won't refuse any service. We should not do it.
Yes,
the problem now is we see a lot of IUDs and some adverse events in pregnancy because of inadequate, improper antenatal checkup.
Yes.
So that should not happen.
That should
absolutely right. That's why in the beginning I said, we are talking of COVID, but I think we should not forget the rest of the obstetrics.
Absolutely. Sir, just to share with you, last week I was listening to one webinar where there was a doctor from Nigeria, and her last statement was very, very important. She said that it is fine that COVID is here and we are being bothered by COVID, but the main maternal mortality still is because of PPH and preeclampsia.
Right.
Forget.
Yes,
absolutely.
absolutely.
Right? So COVID is just very, very small portion was adding to the morbidity.
Absolutely.
So our obstetric, maybe our patient handling may vary as per this thing, but then the challenges in obstetrics are the same.
Absolutely. I think the COVID is gaining more importance because doctors are scared about their protection and the staff, staff
Right.
protection, just the patient, protection. That's the issue, With all these other things, patients are at risk, so we should not neglect that part of the obstetrics also. That's quite right.
Just because you told that majority of the patients are asymptomatic, I just want to put a question to Dr. Ajit. That we had SARS-CoV-1, we had MERS. Now, out of these SARS and MERS and COVID-19, who are the diseases that is more asymptomatic? Do you think SARS-CoV is more asymptomatic?
The SARS one you are asking, no? The one that 2002 that occurred. Actually, that was a severe condition. Actually, about 85% of the patients were having pneumonia, and only say 10% were asymptomatic. But most of the patients were symptomatic for the SARS, and it's again a severe disease with high mortality and morbidity. Then even for the MERS also, maybe only about 25% may be asymptomatic, but the other people are symptomatic and with a high mortality. Say the fatality rate with the MERS was about say around 30%. With the SARS, it was about 12 to 15%. So that much high fatality was there with the MERS and SARS. But coming to our COVID-19, the asymptomatic rate is very quite high. Asymptomatic, or even with a mild flu, about 80% of the patients have only mild symptoms.
Because we have seen in our country that majority of them are asymptomatic.
Yeah.
So it's nothing to be so, worried about it. So if it is asymptomatic, only problem is that it will spread. So the silent spread is there because it is asymptomatic. The more would have been symptomatic, then the silent spread wouldn't have been there. So there lies our precautions are so important for that.
So that is the most important one. The spread is very fast with our COVID-19, even though the fatality rate is only 1%.
Not only that, sometimes the virulence can be there, and though we are talking of high risk contacts and low risk contacts and the time element of the contact, but sometimes the patient is really symptomatic, then even a few minutes contact, unprotected contact with the patient can land in positivity. So that's why one has to be very, very careful with COVID. There was a recent case in Maharashtra where just 7 to 8 minutes, contact with the patient who was brought to the OPD suddenly. The doctor was explaining to the relatives that this patient cannot be taken inside. They requested to just preliminary see the patient, and even by doing that, that doctor himself got the positivity later on. So that's why one has to use protection to the utmost, even whenever we process. I think, Girija, can we see some of the slides?
Suchitra, are you audible now? No.
Unfortunately not. Unfortunately not.
It is telling me it is that sharing my screen, but it's saying that my screen is being shared.
Yes, we can see the screen.
Okay, you can see the screen, sir?
We can see the screen.
When was it that you all lost me? At what time?
Pardon me?
When was I lost? When I was presenting some time back?
No, right on the first slide you will have to start.
Okay, should I start again then?
Yes, please.
Yes, you start.
Okay. So we are going to be discussing about the virus, the infection to the mother and the fetus, the antenatal care for non-COVID and suspected or confirmed COVID infection patients. And this talk has been based on the evidences available from the AIMS telemedicine webinar and the recently updated up-to-date of May 14, 2020. And we all know that SARS-CoV-2 is a respiratory virus, and information is evolving rapidly, and we have to constantly keep ourselves updated about various epidemiological factors. It is known to spread primarily from person to person, first by a direct spread, as PARAG told us about various kinds of precautions that we need to take. And the second route is directly via the touching of a surface or fomites that we say. And we as healthcare providers are recommended to employ strict IPC measures for this. Pregnant women need to follow the same recommendations as non-pregnant persons for avoiding exposure to the virus. And pregnant women with children should exercise caution, especially, and it's been found that the disease is usually mild and asymptomatic in children. Now, the clinical features of the disease are mild, severe, critical, and the overall fatality rate globally has been found to be 2.3%. 81% of the times usually have a mild disease, while more than 14% would have severe disease. And the critical disease is reported in about 5% of the patients, and we have to be aware of this particular classification of the disease severity as clinicians, because especially we are dealing with moms coming to us in labor, and we require to have differentiating between other comorbidities like preeclampsia, eclampsia, ARDS, and so on. Now, there are certain laboratory features which are associated with worse outcomes like lymphopenia, elevated liver enzymes, especially LDH D-dimers, and elevated troponin, creatine phosphokinase, and acute kidney injury. And this again can cause a dilemma when we are dealing in patients who have hypertensive disorders of pregnancy. The clinical manifestations which are commonly seen are fever, fatigue, and dry cough. And pneumonia happens to be the most frequent serious manifestation of infection, characterized primarily by fever, cough, dyspnea, and bilateral infiltrates on chest imaging are what have been found in many places. The FOXI has come up with an excellent good clinical practice recommendation, and that can act as a referral for all of us in points of problem. And the famous 5 questions have to be a part of your history, hence on. Always asking the patient about her symptoms, her exposure, and whether she has treated, because currently many of my colleagues have expressed the fact that many patients are denying or many times hiding this particular history, maybe for the fear of stigmatization. You need to take them into confidence and ask them about this. So it's important to check their temperature every time that they come, and as Parag had already spoken to us, and definitely proactively ask about rhinorrhea and such symptoms that we speak about in history. Now, if you look at the effect of COVID-19 on the mother, there are some viral infections are worse in pregnant women due to physiological changes in pregnancy, relative immunosuppression in pregnancy, but such an evidence is not found to be associated with the coronavirus infection. And pregnant women are not more susceptible to the consequences of COVID-19 infection versus the general population, and maternal disease is not aggravated by pregnancy unless associated with comorbidities. Now, usually pregnant women are young and healthy, and they may have comorbid conditions that increase their risk. And it is known that some patients with severe COVID-19 have laboratory evidence of an exuberant inflammatory response, which is similar to cytokine release syndrome. And therefore, sometimes it can be some sort of a inflammatory response which is coming from the body, which is making them more critical and which are probably making them more infective. And that is something that requires to be identified. Unfortunately, maybe too late by the time we are able to find out who is going to become worse and who is not. And whether the normal immunological change of pregnancy affect the occurrence and course of this response is actually not known. Now, in a large cohort of 147 pregnant patients in the WHO China Joint Mission report and a separate report of 118 pregnant patients in Wuhan, the illness was severe in 8% and critical in 1%, and these percentages are similar to those of non-pregnant and reproductive age adults. So therefore, we have to remember this, that they are similar to even non-pregnant people. And in the severe sequelae of maternal COVID-19 infection, prolonged ventilatory support need for ECMO was found. There were 8 maternal deaths from cardiopulmonary complications. Sometimes with multi-organ failure have been reported in medical literature. These women were generally healthy prior to the SARS-CoV-2 infection. And it is important to note that in one report from the New York City, 10 of the 14 patients, that's 17%, who were asymptomatic on admission for an obstetric indication and found to be SARS-CoV-2 positive on universal screening, went on to develop symptoms during the delivery, admission, or postpartum. And of the 14 initially asymptomatic patients, 4 remained asymptomatic, 8 developed mild symptoms, and 2 developed severe critical disease. Now, these are the various factors that I mentioned. It's always better to look at the SpO2, and if it is found to be less than 93%, or if the patient has any signs suggestive of SARI, she has to be looked at carefully. Now, they should be monitored for development of symptoms and signs of COVID-19, whatever, even if the tests have come negative, even if you've done universal testing or you've not done testing, we all believe that all patients are COVID-19 positive, and so therefore you have to keep looking at them clinically. And in a systematic review, including 356 cases in pregnant women, the most frequent symptoms were found to be fever and cough, and these patients therefore require to be looked into. Rhinorrhea, nasal congestion, anorexia, nausea, vomiting, headache, and possibly abnormalities and smell have been reported in the study. And laboratory findings included lymphopenia in 14%, modest increase in liver enzymes in 5%, and thrombocytopenia in 1%. And these clinical manifestations are similar to those in non-pregnant individuals. Now, this was the study that I was mentioning about, which was analyzed by researchers from the ICMR National Institute for Research and Reproductive Health at PARAG, and they studied about 441 pregnant women and 391 neonates. 50% of the cases, the women resided at the epicenter or were direct contacts of an infected person, and the rest of them had community transmission. And if you look at the comorbidities, which were commonly seen, were hypertension, 10%, and GDM, 9%, and these require definitely a little different care. Now, pregnancy complications of COVID-19 can be preterm delivery, miscarriages, febrile organic toxicity, or need of an operative delivery. And in a systematic review, including 252 pregnant COVID-19 patients, reported that 15% delivered before 37 weeks and 70% were delivered by C-section. And this probable increase in the initial elective C-section was a bias maybe catalyzed by the belief that by delivering the patient, she would be better relieved. Unfortunately, it has been proved now to be an unproven hypothesis, and fever and hypoxia from severe pneumonia may increase the risk of preterm labors, cramps, and abnormal FHR patterns, and preterm deliveries, mums without severe respiratory disease can also be seen associated. Now, hyperthermia during the first trimester is known to be a potent teratogen, and increased incidence of these outcomes has unfortunately not been observed in the COVID because we do not have so much of data. But use of acetaminophen in pregnancy, including in the first trimester, has been shown overall to be safe and may attenuate the pregnancy risks associated with fever exposure. Now, the question about vertical transmission constantly erupts, and standards for neonatal evaluation at delivery of an infected mother and criteria for vertical transmission have not been developed as of now. Assessing the immunoglobulin level for the virus in the cord blood, sampling the neonatal nasopharynx, placental tissue using aseptic technique, and amniotic fluid obtained at C-section delivery could also be tested maybe to identify this. But whatever little studies have been done, no such evidences have been found. In women who test positive for SARS-CoV-2 in the nasopharynx, vaginal and amniotic fluid specimens have been negative to date. So viremia rates in the patients with COVID-19 appear to be low in one study and transient, suggesting placental seedling and vertical transmission are unlikely. Few placentas have been studied and almost all had no evidence of infection. There have been only two exceptions, both severe illness in mums, second trimester miscarriage, placental cotyledon was positive, and between amnion and chorion there was found to be this particular disease. But these are the only two evidences that are seen, and none of the infants were positive for SARS-CoV-2. So the testing for COVID-19, naturally the question comes whom to test. New onset fever, chills, URTI, severe URTI, community transmission, or exposure to a positive case. Which test to perform? The RT-PCR for SARS-CoV-2 RNA by the nasopharyngeal swab, and that is extremely important, and ideally concurrent testing from influenza and RSV, that is respiratory syncytial virus, also has to be performed. And the suggested approach is areas where the infection is active, testing all patients upon presentation to labor and delivery or the day before if a scheduled admission with a rapid test for SARS-CoV-2 is reasonable if testing is available, and I'm aware that it is not very easily available in our country. This is how the nasopharyngeal swab has to be taken and not like this, and that is very important. And the oropharyngeal swab would not have the same sensitivity. And if we do not have any of these testings or have not done or the test is still awaited, please treat all these patients as biohazards and use universal precautions, because we never know, since we are usually, especially in Pune, we are in the red zone and orange zone area, we must be careful. A positive RT-PCR generally confirms the diagnosis of COVID-19. And of course, there are occasional false positive tests. False negative tests on initial testing appear to be common, especially in the 4 days preceding and first day of symptoms, and have been reported in pregnant women. And the sensitivity depends on several factors: the assay, the type of specimen, the quality, and the duration of illness. And if the initial NP test is negative, but the suspicion of COVID-19 remains, determining the presence of infection is important for management of infection control, and the test should be repeated in 24 hours, a few days. Infection control precautions for COVID-19 should continue while repeat evaluation is being performed, and 2 subsequent negative samples generally rule out the infection, and high suspicion of COVID-19 infection and diagnosis required for management. LRTI specimens sometimes may be necessary from the sputum or the bronchoalveolar lavage, and as they may have a higher sensitivity. A chest radiograph is sufficient for initial evaluation of pulmonary complications in most hospitalized patients with COVID-19. And we should not be worried about the exposure of the fetus because it is quite minimal. And even CT should be performed if indicated as the fetal radiation dose for a routine chest CT is also low and not associated with an increased risk of fetal anomalies of pregnancy loss. Some authorities have advocated pulmonary ultrasound possibly at the same time as the obstetric scan for quick diagnosis of pneumonia in pregnant women, which in certain locations would be the quickest way to ascertain high suspicion of maternal COVID. And this is the link here I put up, which can be visited. We have a wonderful YouTube film on how to look for this particular pneumonia. Now, medical and obstetric care of the hospitalized patients for mild symptoms, it can be a home-based care. Pregnant women with mild disease plus comorbidities or or moderate to critical care are hospitalized, and women with severe disease and oxygen requirement plus comorbidities require a critical care under a multi-specialty team. There are various postulations about hydrochloroquine or chloroquine, and there have been no benefits found, however, and there can be certain adverse maternal effects, including QT level prolongation and problems. Hydrochloroquine is known to cross the placenta, and it's postulated to have accumulation in the fetal ocular tissue in the animal studies, but we know we have been using it in our patients in malaria and SLE, and there has been no such depiction in the humans. Remdesivir is being spoken a lot about it, and there are huge trials coming and going about it, but it seems to be used as a compassionate use protocol, especially in the United States. And many of the clinicians and the multi-specialty critical care units, including our own government hospital, is using LMWH in pregnant mothers presenting with COVID-19 severe symptoms. Now, what is the rationale of prophylaxis? Routine pharmacologic venous thromboembolism prophylaxis in patients hospitalized with COVID-19, unless there is a contraindication, and initiate prophylaxis in all pregnant women with COVID-19 admitted to the hospital for management of an antepartum obstetric or medical disorder and or postpartum women with infection, and for antepartum prophylaxis who are not severely or critically ill and who may deliver within a few days. Unfractionated heparin 5,000 units subcutaneously every 12 hours is a reasonable dose, and that is what is recommended by the American Society of Hematology and the International Society of Thrombosis and Hemostasis. Now, the typical drugs that we use, the antenatal steroids can be used as per protocol. Low-dose aspirin can be used as per protocol. Tocolysis is always better to use the nifedipine. No beta-mimetics and indomethacin can be used because there have been concerns spoken about certain use of NSAIDs, especially ibuprofen, only in the course of infection and experience severe disease was found to be there in young non-pregnant patients. However, there have been no clinical or population-based data that directly address the risk of NSAIDs. And given the absence of data, the European Medicines Agency and the WHO do not recommend avoiding NSAIDs in COVID-19 patients when clinically indicated. Now, when the patient is admitted for any condition, maybe she's threatened preterm delivery or for some observation during the antenatal period, what we have to definitely look for is the maternal oxygen saturation. Apart from the general supportive care, is similar to that in patients with ARDS due to other causes. And patients are going to be having acute kidney injury, elevated liver enzymes, cardiac injury, confusing our clinical diagnosis. And during pregnancy, maternal peripheral oxygen saturation should be maintained more than 95%, which is in excess of the oxygen delivery needs of the mother. And an arterial blood gas is obtained to measure the partial pressure of the oxygen, and maternal PO2 greater than 70 units of mercury is desirable to maintain a favorable oxygen diffusion gradient from the mother to the baby and the placenta. Now, the fetal monitoring a specific management issue in the pregnant patients at a viable gestational age, of course. The need for and frequency of fetal testing would depend on the gestational age, stability of the maternal vital signs, other maternal morbidities, discussion with the patient and a family about the considerations of adverse outcomes, probably some perinatal morbidities. There can be Bluetooth-enabled external fetal monitors that can be used to transmit fetal heart rate. Continuous monitoring is recommended in unstable hospitalized mothers and in whom emergency C-section would be performed. And an abnormal tracing might also help guide maternal oxygen therapy. And if patients with stable oxygen saturation, a non-stress test can be performed once or twice daily, as one option would be there to look at the baby. If you require to give any kind of anesthesia, maybe for a cervical encerclage, or you want to perform an MTP or a DNE in a pregnant mother, it's always better to use a sensory blockade by giving the saddle block. And if it is done, typically it can help in avoiding the aerosol generation that we are much scared of. If you look at the antenatal care for non-COVID pregnant women in this particular situation, one has to continue maintaining their diet, hygiene, attention to infection prevention and shielding, and travel and quarantine guidelines have to be given to them. And antenatal advice for pregnant healthcare workers also is extremely important. Attention to infection prevention and do the famous 5 that we've been talking of as a part of social distancing and being isolated. And in patients, when we are talking of non-COVID pregnant women, you should reduce, postpone, and or increase the interval between antenatal visits or routine scan. shorten the duration of antenatal visit, limit visitors, individualize plans, and continue to provide necessary prenatal care, antenatal surveillance for high-risk cases, and do the 4. The minimum contact can be 12, 20, 28, and 36 weeks of gestation, and then, of course, in labor. Now, you can club some screens, for example, tailored for low versus high-risk patients, multiple gestations, hypertension, and diabetes, include telehealth, reducing the number of in-person visits and timing of visits, grouping tests like aneuploidy ID, diabetes screening, infection screening to minimize maternal contact with others, and restricting visitors during visits and tests. Timing of indicated obstetric ultrasound can be gestational age, fetal anomaly, fetal growth, placental attachment, and timing and frequency of use of non-stress tests and biophysical profiles also can be reduced. Now, even moms who are at risk, if they're high-risk mothers, order a 75-gram 2-hour oral glucose tolerance instead of a glucose challenge test. One can perform a cell-free DNA screening instead of doing the combined testing that we are regularly doing. And ideally, every woman should have telehealth capabilities, as Parag was saying. You must instruct the mothers, especially in the 3rd trimester, to talk about counting their own kicks. And you can see here our patients sending their blood pressure record, which they are doing with the home BP monitoring. Likewise, they can do their home sugars monitoring and then guide you as to what's happening to them. And therefore, this is how you require to modify. And I'm sure that to certain extent, I must have helped you to maybe take little bit towards clarity from the confusion that we have. And this is one word which we are very commonly using for COVID today. For unprecedented times, we require to call it a coronavirus time, and eventually all the pieces will fall in place. Until then, laugh at the confusion, live for the moment, and know that everything happens for a reason. Only we do not know what is the reason. Thank you so much for a patient hearing.
Thank you, Dr. GIRIJA. I think you have covered practically all the things, and some of the things that Professor Ajit will also is to cover. But I think the message that you are given, that it's a changing scenario, and we have to be very aware of the new developments that are occurring when managing the patients. At the same time, to keep the patient safe, we have to be very precise in our management, and been many of the routine investigations, but do think the complications that may arise and about prophylaxis of the complication, especially the thromboprophylaxis, which is coming more and more for now, something that we have to look at and work on. I think that part is very, very important. So let's now move on to the next presentation with Professor Ajit. He has from Kannur. He is a professor and head of the department of Kannur Medical College, and he has the distinction of doing a cesarean section, the first one in our country in the patient of who was a COVID positive. So he has a first-hand information when the things were not all that prepared, and now he can tell us what the things have happened now and what preparations and care that we need to take for these patients during the internatal period. And that is very important to us because we spend a lot of time with the patient, not only us but our staff. So these precautions are vitally important. Please go ahead, Professor Ajit.
Thank you, sir. Can you see the slides now?
No, we cannot.
Okay. One correction I would like to say, I am not the first person to deliver a COVID-19 patient in India. Mine was the third one.
Okay.
First was, I think, in AIIMS, and second was in Mumbai. The third, actually, we had in Kannur.
Okay, so still you are one of the first ones. That's okay.
Yeah, okay. Thank you. Thank you. Thank you very much.
We can see the slides now. Yes.
Okay, thank you very much. See, whatever I say, based on small number of cohort studies, experience of similar pulmonary infections in pregnancy, and based on the expert consensus. So all these scenarios may change. Tomorrow, new recommendations may come. Majority of the pregnant women are asymptomatic or with mild symptoms. As Dr. GIRIJA told us, pregnancy alters body's immune system and responds to viral infection in general. This can occasionally cause more severe symptoms, and this will be same for COVID-19. Individual response to viral infections are different for different viruses, but influenza and pregnancy provides a useful comparator. For H1N1, we all know that there is a significant increase in the critical illness in the later pregnancy. In other types of corona infections, SARS and MERS, again, risk to pregnant women appear to increase, particularly in the third trimester. But fortunately, no evidence that pregnant women are at risk of serious complication for the COVID-19. Pregnancy is a hypercoagulable state. Emerging evidence that patients admitted with COVID-19 are also hypercoagulable. So as Dr. GIRIJA rightly mentioned, there is an increased risk of venous thromboembolism, especially because of the reduced mobility from self-isolation at home or hospital admission increases the risk further. How do we manage it? Most of the patients are asymptomatic, and most of the management is symptomatic only. Antipartum steroids can be safely given, but if possible, avoid induction of labor. Planned delivery after swab become negative, but may need urgent delivery in serious or critical cases for obstetric indications or for obstetric indications. Route of delivery, the best is vaginal delivery. Cesarean section is for obstetric indication, or if she is having a respiratory demands condition is very bad and she needs urgent delivery, you may have to go for a cesarean section. Where we admit these patients has to be admitted in the isolation wards. Even the suspects also, there should be separate isolation wards. And use of PPE is very important. The most important thing is, as we discussed, the coverall, the surgical mask, the eye protection with goggles or with the visor, and the head protection, the head cover. There should be separate labor rooms. Ideally, it should be a negative pressure labor room for suspects and positives. You should not mix suspects and positives. And they should not be the same as the normal labor room. Separate OT, a negative pressure OT for these patients. And as far as possible, there should be only minimum staff. And one point we have to remember, for emergency CS, donning of PPE is time consuming. Even though the video shows that it's only 8 minutes or something, it takes more than that. Anticipate this possible delay. So planned cesarean section is not possible in COVID positive and suspect cases. So this point, even you have to discuss with your patient and relatives. And we have to consider a low threshold for doing a cesarean section. So again, if you take all the statistics, most of the patients are delivered by cesarean section. The RCOG, the US statistics, and from the China.
We have lost your audio, Professor Ajit.
We have lost your audio, sir.
I think his connection has gone.
Yeah.
Hello?
Yeah.
Yeah,
Yeah,
in between the...
Yes, now we can got you back.
Yeah. A surgical mask for patient is a must. Need not be a PPE for the patient, but a surgical mask has to be given to the patient. Continuous electronic fetal monitoring during labor is recommended because in Chinese case series, 18 pregnant women in labor, 8 cases of fetal compromise. So there is a high chance of fetal distress. Even from the RCOG studies also, there is a high chance of fetal distress. So a continuous electronic fetal monitoring during labor is recommended. Even otherwise, to monitor in a patient with a PPE is better to have a electronic fetal monitoring. The best labor analgesia is epidural. Endanox is not aerosol generating procedure. It can be used, but should be used with a single patient microbiological filter. So after each patient, you have to change the filter. Placenta has to be considered as a biohazardous waste, and if possible, test for COVID-19 by RT-PCR and it has to be managed properly. And the role of birth companion is a controversial thing, but in our hospital, we are not allowing the birth companion now. Severe or moderate symptoms, if the patient is having severe or moderate symptoms, definitely these patients has to be managed by a multidisciplinary team. Hourly monitoring of the respiratory rate and oxygen saturation is very important. Signs of decompensation are increase in the oxygen requirement, respiratory rate more than 30, decrease in the urine output, and drowsiness, even if the saturation is normal. That means there is a signs of decompensation. Titrate the oxygen to keep saturation more than 94%. Chest X-ray and CT chest should be performed as for a non-pregnant woman. It should not be delayed for fetal concerns. And abdominal shielding may be used. Prophylactic low molecular weight heparin should be given unless birth is expected in 12 hours and continued for at least 10 days after discharge. Diagnosis of pulmonary embolism should be considered in women with chest pain, worsening of hypoxia, or in women whose breathlessness persists or worsens after the expected recovery from COVID-19. Individualized assessment for need of delivery, and if it is urgent, sometimes even you have to go to an emergency section. There is no contraindication for antepartum steroids for fetal lung maceration, even in patients with the severe or moderate symptoms. But urgent intervention for both should not be delayed for steroid administration. And as per the UK obstetric surveillance study, 427 women were enrolled between March 1st and April 14th. It is not April 4th, April 14th. 99% needed level 3 critical care. 4 needed ECMO. That is only less than 1%. That means it is almost the same as the non-pregnant women. 5 women died. The case fatality rate is 1.2% for COVID-19, associated maternal mortality rate of 5.6 per 1 lakh maternities. So it is not very high, but still there's a possibility of maternal mortality also that you have to keep in mind. Median gestational age at admission was 34 weeks, 42% discharged before delivery. 59% required cesarean section, and 20% under GA because of the severe symptoms or urgency of delivery. So here, about 60% of the patients were delivered by cesarean section. Median age at birth was 38 weeks. About 27% patients preterm birth. Even Dr. Girija mentioned that preterm birth is an important complication of COVID-19. But you can see that about about 60% of this is iatrogenic, about 47% iatrogenic for maternal compromise and 15% for fetal compromise. But still, some of the women went for a preterm labor, the spontaneous preterm labor. 10% of the babies, 10 babies required admission in the neonatal unit. 6 babies tested positive during the first 12 hours after delivery, as per the UCOS. Actually, what they have done is that they have done the IgM in antibody in the cord blood or the fetal blood. So when the IgM antibody is present in the cord blood, that means we all know that IgM does not cross the placenta. That means there is an intrauterine infection. So even though all the studies from the China, all these things are saying that there is no vertical transmission, the new evidence is that it is probable. 2 perinatal deaths occurred, but not clear whether it was related to maternal COVID-19 infection. About the neonatal care, it's a very big controversial thing now. There are only limited data. Delayed clamping is possible. So previously in the initial part, we were saying that early cord clamping. Now the recommendation is that we can go for delayed cord clamping. And previously we used to clean the baby immediately after delivery. Again, no early cleaning because cleaning can cause more infection. And test the newborn by RT-PCR. Individualized decision concerning the mother and baby separation and breastfeeding. So as the recommendation initially was, mother and baby should be separated. And breastfeeding is not recommended, but again, they have changed now. The breastfeeding is now recommended. Main risk of breastfeeding is the close contact between the baby and the woman. In only small number of cases, actually, they tested the breast milk and it was found to be negative. But it's not that breast milk contains the virus. The close contact can cause infection. That is the worry. Benefit of breastfeeding outweigh the risk of transmission of virus through the breast milk generally. But again, you have to discuss with your patient and relatives and risk and benefit to be discussed with the parents. If you are planning for breast feeding, breast and hand hygiene is very important, and a face mask has to be used with the mother. Our patients, about three patients delivered here in our college. Actually, all three patients didn't want to go for a breastfeeding. They're quite scared about breastfeeding. So I don't know. We have to discuss with our patients. Then only we can take a decision regarding the breastfeeding. For the postnatal care, regardless of the mode of delivery, 10 days prophylactic low molecular weight heparin for all COVID-19 confirmed cases. Not all cases, at least symptomatic patients, but some patients, if you think that it is a longer course, has to be considered. The postnatal ward, avoid visitors as far as possible. And in our hospital, injury in our hospital was a very, we had 9 cases together. That time in India, the largest number of cases were in our hospital. But now the case number, everything has reduced. Unfortunately, all became negative. 5 cases were the late first trimester, about 12 to 13 weeks pregnancy. Only one ended up in a miscarriage. Again, we don't know whether she didn't have any previous scanning. So whether it was a blighted ovum previously, so that ended up in a miscarriage, we don't know. We cannot blame the COVID-19 for the miscarriage in this case also. 4 cases were third trimester, 3 delivered, 2 were cesarean section. So again, one was a fetal distress, the other one previous 2 cesarean section. The other one was a vaginal delivery. Actually, that was a previous years. It was a VBAC. When for a vaginal delivery, spontaneous labor, when she delivered. And one is on follow-up. Babies, all 2 babies tested, they were negative. Actually, it's again a controversial thing. 7 of the 9 cases, 7 cases we give HCQS. There is why we give HCQS is that there is no evidence that HCQS is beneficial to the pregnant ladies. It reduces the viremia, but again, there is no evidence that against HCQS also. And we are quite familiar in using HCQS in pregnancy. So we discuss with our patients about the HCQS, and from the Chinese studies, they have shown that there is a rapid recovery from the disease, rapid seronegativity in patients on HCQS, all these things. So the patients accepted it. So we gave 7 cases. 2 patients denied. They don't want HCQS, so we didn't give that. 1 case we gave oseltamivir. Again, that reason is the patient is having a respiratory symptoms. So we don't know whether there's a coexistent H1N1 and all these things. And any patient with respiratory symptoms in the pregnancy, we give oseltamivir. So as a general thing, we give oseltamivir, not for the treatment of COVID-19. So this is the statistics in our hospital. Thank you very much.
Thank you, Professor Ajit, for a great elaboration of what needs to be done during labor and postnatally. I think very practical points that you have brought in. People must be appreciating that. Before we proceed to the panel discussion, friends, let me tell you that now this our webinar is being attended by 1150 attendees. So you're all doing a wonderful job. There are a lot of people joining in, and now we have the task of panel discussion. Unfortunately, I will have to leave because I had not kept more time than this for this. But you have Professor Saswati Sanyal, who will look after this, and I hope we can see Dr. Suchitra Pandit. But if we can hear her and we can, get her voice, I think we'll be lucky. So please go ahead, and thank you all, and thank you all for joining. Please excuse me. I will have to leave. Yeah.
Thank you, sir.
Thank you.
Thank you, sir.
So, Dr. Suchitra, is she audible?
No.
No. Okay. So let's put this straight away. We go to the question. I want to ask Dr. Girija. You said that
can you hear you? Yeah.
I think Dr. Suchitra has come to.
No.
Again, she is not audible. Yeah.
Yeah, now it's audible.
Audible?
She's saying carry on.
Carry on.
Carry
Okay.
on.
Now,
These are ideal lip things. Yeah. Lip read.
Yeah. Common presentation, as you say. But I think some of the patients come with conjunctivitis, and we have seen one patient. She died here, she was not a pregnant baby. She came with pain in her leg, and her disease was, and also she had diarrhea. But the chief complaint was pain in her leg, for which she moved from one hospital, one center to other, and then finally she landed in BVCI, and she had diarrhea also. But posthumously, it was diagnosed with COVID-19. So as you said, myositis, myalgia is there, and maybe you never know if you have said that thromboembolism, small vessels. Yeah.
There
So
can be a component of claudications.
Yeah. So is there anything, something like COVID foot? Have you heard about it?
I have not read in whatever I've read, but maybe we can always keep this open because there's so many information coming up that I've not gone through whatever I've read. I've not read about this.
Okay.
But myalgia, thrombosis, and diarrhea is known to occur.
Yeah.
As well as the viral.
Yes. Now, I want to ask Dr. Parag. He's not here? Okay, anybody can ask this question. Now, when you are doing an ultrasound in a patient with antenatal period, what are the precautions you are going to do in a patient who is COVID, or you want to delay that ultrasound?
First of all, we can space out the antenatal visit, that's one. But in the centers that we are working for, most of our radiologists are wearing gloves and they're wearing face shields. And our head of the department has done a wonderful plastic kind of a partition and a small aperture through which she puts the probes in, and then you can see, so that you are reducing the exposure to the patient's breath. So this we have to observe, because anomaly scans can take a longer time. They may take about 19-20 minutes. So it's always better to wear a mask, as Sir said, maybe an N95 or maybe a double mask, and then you wear a face shield. And even insist that the patient wears a mask. It's important that the patient wears a mask.
Yeah. Now, just because you are talking about mask, is that cloth mask is enough? Cloth mask. The people are using nowadays.
3-ply mask is good enough. A 3-ply mask, and there is a test which says that you must try and blow out of the mask. If you cannot blow out a candle, that means the mask is adequate.
Because there are some few controversies in WHO's statement regarding cloth mask, and there's a little controversy. So the cloth mask,
in the middle, some people have said there is no use of wearing any kind of masks also. But I don't think that is so, No,
I think it's always better to have a mask, because we know at least for sure that it is spread by droplet infection.
We know it's a respiratory infection,
Yeah. So 11 to 13 weeks scan, you want to delay little, or because you will do with all those precautions. That is for sure. Even if she comes at that period of time, because that is an important screening test, isn't it?
Yes. 11 to 13 weeks is an important screening test. But some of our patients miss them because of the sudden lockdown. Then we suggested that you can do it at 16 to 18 weeks, where we clubbed it with an early anatomy scan, a cervical length assessor, and then you can do the quadruple marker test, if at all it's a high-risk mother. Or then we directly push them on to 18 weeks anomaly scan. You come at 18 weeks, we'll do an entire structural scan and time your OGCT, asymptomatic bacillus screening and everything around that time. So that is how when vaccination for tetanus and everything was plugged that time. So you have to mix and match with the convenience, for the patient, but you may not be insistent with the protocol. And I think you should be careful of those patients who are also not reporting. Your facility should find out at least the ones, like when we have less number of patients, they are booked with us. Are they doing well?
Yeah.
Why are they not coming? We can always talk to them and find out what is their health status.
That's a great idea. Yeah, that's very important. Now, Dr. Ajit, you said that preterm labor is one of the complications. Dr. Ajit, preterm labor is one of the complications of this disease. Now, do you want to give them anything to prevent the preterm labor in a patient who is in the late trimester?
See, I think one of the most important components, apart from the inflammatory factors and their baseline risk, is anxiety. a lot of anxiety. Nearly 50 to 60% of women are suffering from anxiety. You will find even in labor, they will have discordant uterine activity, they will have meconium stain lico. So many problems happen. So therefore, unfortunately, there is nothing which has been, sort of evidence, whether giving anything. All the preterm risk assessment that we normally do, like anemia, infection, and cervical length, and then follow that in tandem is the only solution we have. Inflammatory markers exist. Maybe inflammation is a reason. Some people have used indomethacin as tocolysis, but I don't think that's something that we can say that this has to be used as a prophylaxis for preterm labor in COVID pandemic.
Yeah. Yes. So just I want to know if the patient has come with cough in the mid-pregnancy, just cough, and you are suspecting. Now, what will you do? You will do the testing and you send her home, or you put her in isolation, or you do hospital quarantine. What your plan?
You are talking to me or to sir?
Dr. Ajit can take this question.
Yeah, if there is only cough, no, and there is no contact history or anything, just we will be treating as a upper respiratory infection. We don't isolate her. Only thing is we tell them use a mask and home isolation.
Okay, just use the mask and
just
home
because
isolation.
Cough, we don't admit the patient.
And wait for
even
her.
Home isolation, I don't know. But just because of a respiratory infection, it's not nice to isolate a woman. So again, we have to. The only thing is you have to take precautions. And if it is persisting, or if there is a fever or something, then you have to come to the hospital, or we have to inform the health worker. They will arrange the swab test.
Okay, so you can send, if it is a mild symptom, you can send her home, but tell her to be at least in the home, she should stay like that. So, Girija, you told about the stress, and I think there is one study that has told that the stress is one of the important factor for all those complications that occurs even in SARS, MERS, and all those. There is a systematic reviews also there regarding stress. Now,
yes,
there is one thing has come up. I have heard that. Is there any role of famotidine? There are some paper has come out that famotidine has got something to do, which it reduces the mortality as well as ICU admission. I don't know. Some people are working on that. Okay.
Actually, I was just speaking to our government hospital, who is delivering a lot of COVID patients in Pune, and I was asking them because they were not doing universal testing in the patients, but now recently they have started doing universal testing. Because they found that asymptomatic patients came in labor and then became symptomatic and became severe. So therefore, that's one. They are not using any antiretroviral, none of the antivirals they are using. They are only using azithromycin, and they are using LMWH. And then, of course, the symptomatic management, whatever are necessary for the secondary infections. So
and there are some studies from China that famotidine is useful. Especially what they have done is in elderly patients with heartburn, taking famotidine, there was a better cure rate. There is a reason for this suggestion. But again, we need more evidence to suggest a famotidine for
COVID. You don't have enough evidence anywhere. Yeah. This is a question for Girija, because we already have so many problems. We have seen a patient comes with, she is hypertensive and she has acute pulmonary edema. Now, in this case, this will be, it will also be, you can take it as SARI as well. So what is your advice? Can you differentiate between a pulmonary edema of this COVID, or it is as a pulmonary edema of hypertension?
The X-ray CT scan reports which have been studied up till now and which have been spoken about, you will find that in the COVID-19 affected pneumonia, it usually starts with a peripheral opacity on an X-ray chest, and then there can be consolidated areas, and these consolidated areas in some patients have also been called as COVID balls. Now, these are something which are not seen in ARDS, which is associated with preeclampsia. If you look at the ARDS with preeclampsia, it's a generalized opacity which is seen.
Yes.
So these are the only things that we can probably think of. And of course, as the healing goes on with the ARDS associated with COVID, it's usually associated with fibrosis kind of a thing. And so therefore, all these pictures would depend on the duration of the affection. But in the beginning, they would say that they are usually start from the periphery and then they are patchy. That's what they have said. The areas of consolidation are patchy on the X-ray. And so these are the things which I only, in this question, this Saswati came to my mind also. How are we going to differentiate HELP, preeclampsia, and so many other issues related to
pathology? If they're going to the same thrombosis,
and so it's an inflammatory process which, is causing havoc.
Very, very confusing. But if you want to differentiate that way, I think your threshold for doing a chest X-ray should be low. You do it as early as possible.
And that's exactly why I mentioned about that, because sometimes we are not having an access to the COVID testing. We are not sure about its sensitivity and specificity. Maybe X-ray chest can tell you. Oxygen saturation is another thing which you can do for these patients periodically.
Yeah, oxygen saturation will be low in case of even for hypertension as well. So now let's go to the labor. Now, as Dr. Ajit said, that most of the patient goes for cesarean section. Now, is it for the logistic reason, or it has got its other things? Because you don't have so many people. Labor goes on for so many hours.
So that is a big question, because most of the patients are delivered by cesarean section, and practically also it's not that easy to put a PPE and monitor a patient for more than 6 to 8 hours. So if you think that there is a prolonged labor, and then if you need a crash cesarean section again to put a PPE is very difficult, and there will be some delay in doing a cesarean section. So I think what we do is we have to plan a low threshold for cesarean section. Not that a patient with a very progressing very fast, of course you can put for a vaginal delivery, and if you think that she will take long time to deliver, then we have to consider doing a cesarean section. That is the best thing.
One of the most important, Saswati and sir, one of the most important dilemmas is induction of labor. See, now some of my patients have crossed 40 weeks of gestation. And they are insisting that let's wait for 2-3 days more, everything is fine. Now, normally as a protocol, we do not wait for more than a week or so. And then naturally the stress and everything, we are wondering, they are hopeful that maybe the lockdown will stop, maybe things will reduce, so then we'll deliver later. And then some of them want to be induced earlier. Now, these are the things where I know there are no guidelines. But induction, we know, takes a longer time to labor and finally deliver. So how do we go about this?
So, Dr. Ajit, if you are going for a normal delivery, because Dr. Parag is not to be seen, I don't know why. So I have to put on.
He connected. Parag. Hello, Parag.
He's not there. So I just want to know, because our postgraduate students, they are only on duty.
He said he can only hear.
Okay. So can hear. So for these patients, if you are doing just an auscultation with a stethoscope, how frequently you should do that? Because you cannot go for the standard way of doing it, monitoring.
It is not practical to do a auscultation with full PPE. It's quite difficult. Either you have to use a handheld Doppler or a CTG. So what we do is a CTG only. CTG. CTG is the best thing. Continuous electronic.
Continuous recording, and if you have the Bluetooth one, you are lucky, which we don't have very easily in our setups.
Yeah, but if you have a CTG, you can see from a distance that everything is going on.
That's the best thing.
I think that's the best thing one can have, that the labor room should have a CTG for those COVID-19 positive. Even
Saswati, in our government hospital in Sassoon, they have 15 to 20 beds in labor room, all connected to CTG on a big monitor.
You are lucky. But we have three at least. We have three, but this is one of the important thing. I think that should be a kind of standard, that if you are doing it, because you cannot do cesareans for each and every patient. That is also another logistic problem. So if you're going for a normal thing, it should be a kind of norm that it should be a CTG monitoring for the benefit of everyone. I mean, it is
some sort of chambers. We have chambers where there is constant circulation of an disinfectant which is going on, and we deliver mothers there.
Is there any role of UV ray? Because we have UV ray in our one of the COVID hospital they have going to install. Is there any role of that UV ray that you put in the labor room? Anybody?
There is no evidence. Whatever they are talking of is
There is no evidence. There's no evidence. Yeah.
I think, Saswati, we should close down. We finished 1 hour 41 minutes.
Great.
So we have another, as promised, we had promised 1 hour 30 minutes to them. We can take 10 minutes for the technicalities.
Okay. Because for normal delivery, there is also soiling with that fecal matter and all. Those are also questions whether you should go for vaginal delivery. So many things are there because we don't know whether the bacteria are there.
See, the fecal matter, the thing is that, again, it's a controversial thing. It is a late manifestation. Sometimes it takes about 1 month, and again, whether it's an active virus, we don't know. Mostly it's a RNA, inactivated RNA that is coming through the fecus. So fecal transmission itself is a controversial thing.
Okay. For breastfeeding, I would say that bedding in and then express breast milk also can be an alternative, I suppose. Not bedding in, rooming in. Just put the baby in the room and express breast milk can be given probably by cooking all those, the sanitizing the other way to have a better, for our people in our developing country like us, we should give the benefit of breast milk to the baby. I think we can stop here, and it is an excellent to interact with all of you. And Girija and Dr. Ajit, you have done an excellent job. Thank you so much.
Thank you, Saswati. Thanks a ton. Thank you, sir. That was very nice, and congratulations.
See you. Yeah, see you.
Bye.